Yeah.
All right. So we are going to, I'll do a brief introduction. We have Rosalia Njau with us today, who is currently one of the fellows in the TREC G43 supplement, learning about implementation science, in addition to her work on a newly funded grant, which I'm sure she's going to mention, working on elderly trauma. And that's what the paper that she's sharing with us today is about, which we'll certainly share the link to that published paper about looking at the differential outcomes depending on age of patients at KCMC. So without further ado, I will turn it over to Rosalia. Welcome.
Hi everyone, morning and good evening. Yeah, so I'm so glad to have this opportunity to present to you one of our paper in the elderly trauma team, from the elderly trauma team. And the paper is on, it's looking at comparing the injury patterns between elderly and the adults. Yeah, so it's titled "The Older the Injured, the Worse the Outcomes." And as Ashley has introduced me, I'm a medical doctor and a researcher with a master's in epidemiology and applied statistics, and currently I'm an implementation science fellow. Right now I'm in Durham and having an exchange program in Cuba. So we published this paper in PLOS Global Public Health, and this is the list of team, and we also have Edwin. I'm not sure if he's here with us, but also our mentor, Dr. Catherine Staton. The contents of my presentation. So why did we decide to work with this population? So the elderly population is currently rapidly growing, and especially in the low and middle income countries. And it's anticipated to double the population is anticipated to double by 2050. This is not very far from now. Yeah, and trauma, as the population is increasing, the number of trauma patients, elderly trauma patients, is also rapidly increasing. Now, with this increased burden, the low and middle income countries especially is not really prepared to really work with this population and help them, because we, like KCMC, we don't even have a geriatrician. So you can see that we are really not ready to really overcome this challenge and this injured population. So we had an objective with this study to compare, as I said, compare the social demographic, clinical characteristics, and injury patterns, and in hospital outcomes between the older adults who are above 60 years and above, comparing them with the younger ones who are 18 to 59 years. So the setting is Kilimanjaro Christian Medical Center, and these are the pictures showing the ELD, and outside the ELD, inside the ELD, and also the picture in between shows the theater. These are surgeons working. And coming to data exclusion, so we are glad that we had the registry that we could analyze data from, and we used the trauma registry data from 2020 to 2024, including adults aged 18 years and above, comparing the two groups. And we had a total number of 3,296 participants. And comparing the demographic characteristics, sex, we comparing it with the adults, the younger adults. We normally see that males are more prevalent coming to injuries, but for other adults, the difference is a bit narrow compared to the younger ones, and the difference was significant. And coming to the education level, here we are glad because for the older adults, the proportion of those that have primary education were a bit higher compared to the lower, and comparing it with younger adults, at least now that the gap is narrowing. So this is good news to us that at least now people are having more education compared to the past. And insurance status comparing with the younger adults, older adults had a higher proportion of participants who had insurance, and this is a good thing. But I think this is because of the chronic illnesses within this group. Then they have to have, they realize that they have to have insurance. And alcohol use, with the older adults, the proportion of injuries due to alcohol use is a bit lower compared to the younger adults, and I think we expect this. And the chronic illnesses also is more prevalent among the older adults. And coming to injury characteristics, so most injuries are fractures among the older adults, and they also need hospitalization after the injuries. They need more hospitalization than the younger adults, and this is because they get more severe injuries and need hospitalization. So the mechanism of injuries, for the older adults, the most prevalent mechanism of injury is falls, and comparing it with the younger adults is road traffic injuries. So we see a need to prevent falls in older adults. And older adults take longer time from injuries to the healthcare or to receiving healthcare, and this I think this is not good, because the older you are, the earlier you need to be treated so that you can reduce the hospital stay and complications. And also mortality is higher among the older adults compared to the younger ones, although we cannot really attribute this to the injuries because of the analysis that we did. It was just descriptive. And the length of stay is also 4 days longer compared to those with the younger adults. So we see that older adult patients have unique needs. They stay longer in the hospital. They have comorbidities and worse outcomes, and suggest we suggested from this paper to implement an older adult specific clinical practice guideline. As Ashley said, we are now implementing a CPG adoption at KCMC through the R21 Elderly Trauma Grant, and we are hoping that from this grant we will come up with a CPG that will help streamline and improve care for the older adults. This is just a step towards improving care for this group, and we hope to do more. We are going to do more for this thing. We are also thinking of from the paper. We also suggested that there is a need for increasing specialized training for geriatrics, because as I said, we don't have a geriatrician, and also the care for this group is not really that streamlined at KCMC. They're just treated as any other group. And fall prevention is one of the interventions that we really need are thinking about to concentrate on, because there is a significant need from this analysis of the scene. And also, yeah, so it was a brief presentation, but I have this beautiful picture here of my grandparents. These are my dad's parents. They are with the Lord now. I lost both of them, but I have them here because the reason why I decided to work with this group is because back at KCMC, if you are a doctor in the family, then you are the one taking care of. If anyone comes to KCMC and they need medical attention, then they'll just take on you. And because my parents also live far away from Moshi, so I was a bit more concerned to help them. But my grandpa was able to ride a motorbike until he was 76. He was very fat. But one day he had a shop. He was going to take some goods from Himo town. My grandparents lived in Kilema. So he was going to take some goods in Himo town, and he hit a rock while he was going there with a bike, and he fell on his right limb. He sustained a tibia fracture. And from that time, he had a cast on and was immobile. He had no hypertension, he had no diabetes, but because of the immobility, he was not any more active. He developed diabetes and hypertension. And making the story short, that is what led to his end organ failure and things like that, and we lost her. And then my grandma was also very fine. She is my height and was able to take the bananas from the tree. She was very active, very fine. But one day she injured her hip and she was a bit stubborn, so she didn't want any surgeries on. But this made her a bit immobile, and she didn't have hypertension or diabetes, but she developed the hypertension after that. And yeah, the story shows in two years after my grandpa's death, we also lost her. So this I felt like I felt them somehow, but this gave me a reason to really think of working with this population, because as I was helping them with the treatments at KCMC, I saw a lot of gaps. Like, I wish this was better. I wish this was better, because I was on the patient side. I was on the doctor's side, so I saw things better. And I think there's a lot to do with elderly care. Really is a lot to do with elderly care. And I'm glad that we are at least one step with the CPG. Yeah, thank you.
Amazing. Let's thank Rosalia for a really wonderful presentation. And thank you so much for sharing your lovely grandparents and their story with us. That's really great. I think a lot of us can lose that personal story, that reminder that we're talking about real people in this data. We'll open it up for questions. There were a lot of comments in the chat. I think we're gonna have a lot to talk about. So that's really exciting. The paper is in the chat too, if anybody missed it. Feel free to check out the full text. I'll just flag a couple of things briefly. Catherine was flagging that although it's less for older adults, alcohol use is still concerningly high with these injury patients, which is really important because alcohol withdrawal and delirium can be more complicated for that population. And I was pointing out too that, yeah, especially when we're talking about road traffic injury and crashes still being a big thing, that can obviously have to do with alcohol as well. Thanks for pointing out the sex differential. I think that's that's an important thing to note, which made Anna and Natan come to the convergent conclusion about falls in women, which are increased with age, related to bone density issues, which made me wonder if you looked at like sex stratified mechanisms of injury to see, I think that it's probably very likely that men and women are at that age group are still having different mechanisms of injury. And there was a little bit of discussion about the sample size, which the question that Charlotte raised, I wanted to point out two things. So she said the sample size in the adults, the younger adults is a lot bigger than the older adults, which we would expect because the population of those over 60 is much, much smaller. And I think even still with your sample, the older adults are overrepresented than what they are in the population. They're disproportionately showing up in the registry because they're a small amount of the study or the population at large.
I'll add some numbers to that, Ashley. So 13% of the population is older adults, 10% of the population in general, not those showing up to the emergency department, are older adults. And so by having 13%, we're having increased injuries. Now, that actually is really concerning because of the fact that road traffic injuries and young adults are very well known to have far more prevalence of injuries. And while we see that in this environment, we still see a really high proportion of older adults. That might be because it's a referral center. And so many people are coming from a much broader area, and that's where we're getting these higher numbers. But even still, that's a pretty large impact on the health system.
And then one other thing I wanted to point out, which is relevant to this question that Charlotte raised about the population balance in the sample, and also about the question of, why are older adults not coming, or in the case of the disproportionality, are younger folks not coming? And you pointed out about the delays, Rosalia, that the older folks are having more time to get to care. I wanted to point out something about the methodology of the registry that's important to take these results, which is that the trauma registry at KCMC only includes people who are seeking their initial care, like their what's the word I'm looking for? Their index visit for an injury. So if these people went to a clinic before showing up at the emergency department, they like a week ago, and then they went home and then they came back to KCMC emergency department, they wouldn't be excluded. So that could have some influence on what looks like a delay, but perhaps people who would have, it could change the way the two sides are showing, those that have a delay and those that don't, because the people who actually showed up earlier are completely excluded, or if they were not seen at KCMC, if they were seen somewhere else, and then maybe got worse, they wouldn't be here. So that could have some effect on both sides. But I know there's other questions and comments. Mac had a question, Rosalia, if you can address it, I'm not sure. How prevalent are blood thinners and antiplatelet medications in Tanzania? That could affect some complications and what you were mentioning too. Any idea, Rosalia or Edwin, any co-authors can respond to that.
I think we do have blood thinners and antiplatelets, but I think I'm not sure about the regimes. When should they be given? Are they given for like prevention? I'm not sure about that, but I know we do have blood thinners.
So I'll help out here a little, Rosalia. So in the United States, we have a significant number of trauma patients because they fall and hit their head and they're on blood thinners. That is not what we see in our registry. We see a very small percentage of minor traumas, and they just happen to be worked up because they're on blood thinners or antiplatelet agents. We do see antiplatelet agents amongst a good portion of the elderly population, but I would say a good portion is more like 30%, because of limited access to medical care and a limited understanding of cardiac risk in the setting. So not very many people are on antiplatelets. And I would say I've seen a handful of people on true blood thinners, because I think it's more limited in terms of access. So I don't think we have the same challenges we have in high income country settings.
Does well, first, great talk. Obviously, everyone's like giving lots of compliments. It's really fascinating. And as someone who takes care of the complete opposite end of the population, it's definitely not as versed in like geriatric care, but does the registry cover or like have a note if someone has like repeated injuries? Because my recollection of like in the US population, there's some like frequent fires, frequent falls, frequent injuries. And I mean, the reason I put my original question in is I feel like in the US, we also have a chunk of our elderly population that's like, I don't need to go to a hospital or just like doesn't want to engage with the health system. It's almost like you can kind of be on either end of the spectrum in the elderly population. So I guess like, does it track repeat players or you can only be enrolled once in the registry? And then culturally, do you see like that some people go to a hospital a lot and they're elderly and other people want to stay at home? So I guess that's kind of two questions.
Yeah. So for the first question, the registry doesn't have the repeat. Like this is the first visit, the second visit. Yeah, we don't have that. And for the second question, yes, and especially for elderly patients, most of the times they won't come to the hospital. They would end up with traditional medicine or just decide not to have any intervention on the fractures. Like I explained with my grandma, she didn't want any surgeries on her hip. So I think that is a huge problem. So,
I know a lot of people in Gemini look at like pre-hospital care, access to care. My sense is that the elderly population is probably a high risk area if they're like under utilization or under access there.
Yeah, if I could add in here, from a health system standpoint, you have to pay to get care. And so in the United States, you don't really. You might get a bill, but like nobody follows up very much. And you can always have indigent care. And so very often people will not come to get care, just because of the costs involved, and they will estimate what they need and choose not to do it. So I think that that is also erroneously bringing the numbers down. But I do want to talk about the health system burden that's here for this unique population. If you look at some of Rosalia's data, for the level of consciousness, the percent that have an abnormal level of consciousness is 2% in comparison to younger adults, meaning the overall sort of stability of the patients and their injury scores are much less. If you look at the KTS, which is a level of injury score, when you're looking at older adults, it's 86% have mild and 27% amongst the younger adult have mild. So it's a huge difference. They're very mild injured patients, theoretically. But then when you look at their outcomes, it's markedly worse, and the hospital length of stay is markedly worse. And what this tells us is that we have focal fractures, right? So they're with it, they can talk. It doesn't mean that they have this whole system injury, but they have a fracture that's going to have significant morbidity and mortality associated with it, especially with a system that's not supported for patients of this caliber. And then because of the hospital length of stay, It requires a significant amount of health system needs and finances. So it's a very costly hospital stay to have both surgery and to be there for 10 days, especially amongst a population that's no longer working. So the burden on the health system, if we think about this from a health system standpoint, is really very high, never mind on the family itself. So it might impact some of the decisions that our elderly populations are making to not go to the hospital because they're worried about their burden on the family. Amazing, Rosalia. Really nicely done.
Great points. Other questions or comments? I wonder, Rosalia, if you want to talk briefly about the new project that's starting and how it's going to add onto this work a little more.
Yeah, so
Yeah, because Charlotte's saying I'm creating a qualitative study about decision making amongst older adults about accessing care, and that's the same thought that I had as well. Was yeah, we need to explore like what's happening there. So go ahead, Rosalia.
so with the current project, we are looking at adopting a clinical practice guideline called treatment, and we are going to we are analyzing right now. We are analyzing data right now to see to just describe sorry. We are working to describe the data, and then we will co-adopt the guideline at the END, and we'll use a few number of patients and see if and do a qualitative study to see if it is really doable at the END. So we are at the initial phases of the project now.
Very good. Yeah, obviously everyone here is very excited to see how that comes along.
Yeah.
Other comments or questions?
I'm just excited. We got the neonatologist of the group excited about older adults as well. The whole spectrum.
Yeah, anyone in diapers.
And Charlotte put another comment there on this thread of like looking at the barriers to care, including kind of the process and decision making. Are we looking at some way to, obviously we have a hold on patients who access care at KCMC, but what about those who don't access care maybe at all or at this tertiary center? You know, are we going to be able to get that perspective that's often missed because we're sampling from the hospital instead of necessarily in the community? Any thoughts about that or plans?
Yeah, I get Dr. Shala's concern. Yeah, there is a really you'd need to do a pre-hospital study. Yeah, and I see Alice is nodding her head because she likes pre-hospital studies. Yeah, so I think we are going to work. As I said, that there is a need also to do a study on prevention of falls. So I think that will be a pre-hospital study. There is a.
It's obviously much harder, right? Because like when the patients come to you, it's much easier to like accept their views than like having to go find who's not coming. Really great like line of research that all of you guys that are on this crafted and are working.
Very good. Any final questions or thoughts? Any final words from Rosalia or any of the other study team?
Yeah, I see Eden is here. You're welcome.
Yeah, I just want to thank you, Rosalia, for a great presentation, and also excited to move this project along. For sure, the older adults need us, and we might make an impact on that population. And I'm sure your grandparents will be proud where they are.
%. All right. Well, thanks again, Rosalia. Join me in thanking Rosalia for an excellent presentation and the study team. Well done. Congratulations. We'll expect an update when you guys have some results from the elderly trauma project. All right.